This conference will now be recorded.
Okay, thank you. Touching, huh? Okay. So today's topic is cerebral palsy. So first we'll in first slide we'll deal with the evaluation. What is cerebral palsy and how to evaluate it. Then we go for its management. Okay. So cerebral palsy generally it's an insult to the brain during the childhood. Okay, of the patient, where when the child was born. Okay, and there are multiple causes. We'll see it. So first, William John Little, the first clinical report of CP. Then Osler coined the term cerebral palsy. Sigmund Freud, complete description of CP. So cerebral palsy describes a group of permanent disorders of the development of movement and posture causing activity limitation that are attributed to non-progressive disturbances that occurred in the developing fetal or infant brain. So actually the damage is within the brain, which affects all the muscles, okay, all the bones, posture and development, everything. Okay, so cerebral palsy is the result of a brain lesion. Spinal cord and muscles are structurally normal. The problem is within the brain, and depends upon the location of the brain that got affected. So the features will be there. So brain lesion must be fixed. It's fixed and non-progressive. All progressive neurogenesis are excluded from the definition. Abnormality of the brain results in motor impairment. So what are the factors? What are the etiology of this? Is prenatal brain malformation or vascular events, infection, metabolic disorders, toxins, genetic syndrome, preeclampsia, antepartum hemorrhage, multiple birth pregnancy, in utero death of co-twin, then perinatal or preterm birth, low birth weight, intrapartum. So what these are all will leads to insult to the brain. Okay, so hypoglycemia, infection, low placental weight, low Apgar score. So they're all the multiple causes. So and if you take the proper history from the parents for any cerebral palsy patient, there will be a ICU stay. 99% there will be ICU stay for the baby. So postnatal infection, meningitis, septicemia, traumatic brain injury, near drowning, stroke, seizures. So these are all the multiple causes which leads to some insult to the brain. Okay, so based upon the area which got damaged, the clinical features will be present. So for suppose the pyramidal tracts area was damaged in the brain, it will give the spastic paralysis type. In extrapyramidal, we get coriform, ataxic, hypotonic, ethetoid, and rigid. So based upon the structures got damaged, there will be different presentations like monoplegia. Okay, monoplegia, one extremity is involved, usually lower extremity. Hemiplegia, both extremities. Usually upper extremity is involved more than the lower extremity. Whereas paraplegia, both lower limbs are equally involved. In diplegia, lower extremities are more involved than the upper extremities. See, in diplegia, lower extremities are more involved. Then quadriplegia, all extremities are involved equally. Okay, double hemiplegia, all extremities involved, upper more than lower. So total, these are different. This is the classification, geographical classification of cerebral palsy. Okay, hemiplegia, diplegia, quadriplegia, and this is extrapyramidal types: ethetoid, dystonic, and ataxic. So how to assess the child of a CP? So speech evaluation, IQ assessment, psychological evaluation, ophthalmological evaluation, occupational therapy, neurologist evaluation, and orthopedic assessment. So orthopedic, so we deal only with orthopedic examination. So we have to check for which part of the area got involved. So to know it, we have to take some proper history, do some physical examination, gait analysis, and then histopathological. So history, proper history, we have to take birth history, birth weight, gestational age, complications, any ICU stay, any ventilatory support, okay, and any medical, so like visual abnormalities, any swallowing difficulties, any speech or seizures, and motor milestones. Motor milestones will not be achieved as a normal baby. Generally, they in spastic they will be very stiff, whereas in floppy or else it may be floppy. Okay, but in spastic it will be very rigid. Okay, and the stiff extended legs, unable to lift it. So milestones will not be achieved properly. Then muscle tone assessment. So physical examination, we have to check for the muscles. So based upon the affection of the muscles, we can understand which area of the brain got involved. So muscle tone, muscle strength, selective motor control, balance, equilibrium responses, muscle length examination for shortening, joint deformities, torsional bone deformities, and then gait analysis. So muscle tone. So this tone, spasticity and rigidity, we know how to measure. These are all velocity dependent. So whenever we repeatedly flex and extend the elbow or flex and extend the knee, then we'll come to know whether it is flaccid or spastic. Okay, like that. So to know the tone. And operate only when pure spasticity, avoid when dyskinesia and mixed pattern. So only in spastic conditions we have to operate. In other conditions we shouldn't operate. This is the muscle tone assessment. How to assess the muscle tone? Okay, 0, 1, plus 2, 3, 4. These and all are need not require very this much depth. Okay, but you should know, understand the minimum thing. What is cerebral palsy? Okay, what are the different factors causing it? And in ortho, what is its importance? Okay, selective, but I'll tell you all the surgeries which were done in orthopedics. But in those, if you mention the names also, more than enough. You should understand the basic concept, what is leading to which deformities, okay, which contraction of muscles. Basically, to know the cerebral palsy, you have to know all the anatomy and functions of all the muscles, lower limbs, upper limbs, particularly lower limbs. Okay, and muscle strength, manual muscle testing or handheld dynamometer, and posture and balance during sitting, standing, and walking. So children with CP have deficient equilibrium responses. Posterior, anterior, lateral equal response should be evaluated. Poor balance requires supportive devices. And there is something known as gross motor function evaluation. The GMF score I'll tell you later. So assessment of contractures. So mostly we'll deal with spastic because most of the cases of cerebral palsy are spastic, and only spastic conditions will be treated surgically. Okay, so what are most common muscles that go into spasticity are hip flexors, hip adductors, knee flexors, ankle plantar flexors, foot inverters, and everters. And there are different tests to know which muscles got affected. Thomas test, Duncan-Ellie test. So Thomas test for iliopsoas muscle, Duncan-Ellie test for rectus femoris muscle. Like this, for every muscle there is a specific test to know which muscle got affected. Okay, so Stahel's test, Phelps-Gracely's test, popliteal angle cerebrospinal test, flexion withdrawal test. Like these are different tests. Ober test for iliotibial band. Okay, so Thomas test generally for iliopsoas. Iliopsoas is hip flexion. Okay, in Thomas test, what they will do is, if there is any hip flexion deformity, there will be exaggerate of lumbar lordosis. So we will obliterate the lumbar lordosis and see how much angle, okay, how much angle there is between the thigh and the lower couch. So normal there will be no space here, but in abnormal things, whenever there is flexion deformity, there will be a space here, and we should calculate this angle. So then we can know that there is a flexion contraction of the iliopsoas. Iliopsoas is the muscle which helps in the hip flexion. Okay, see, very important, what muscles, what is the function of these muscles is very important in understanding cerebral palsy. And this Duncan-Ellie test, so this is the here we know about the iliopsoas, but here we'll come to know about the rectus femoris. This Duncan-Ellie test, this is a, see, whenever there is rectus femoris tightening, so rectus femoris will be from anterior inferior iliac spine and it will insert into the patellar tendon. So whenever it is very tight, so if we flex the hip on the prone position, it will contract and it will cause the elevation of this hip from the couch. Okay, so normally we will not find this, but in contractures we will find the elevation of this buttocks. Okay, this test the spasticity of the rectus femoris. Prone, keep the patient in prone and each leg is flexed at the knee. If the patient has a tight rectus femoris or hip flexion contracture, the hip on the same side will flex, raising the buttock of the table, off the table. Okay, so like this, by each and every test we can know what muscles got contractured, and based upon that we can know what part of the brain got affected. So first, Gracely's test, this is for Gracely's contracture. Okay, patient is prone and the examiner passively abducts both the hips as far as possible, then flexes the knee to 90 degrees and tries to abduct the hips further. So if abduction increases further, then test is positive. So it indicates that Gracely's contracture. See, while extension it is not abducting, but while flexion it is abducting, because while flexion Gracely's will be relaxed. So therefore, because Gracely's semitendinosus, this all will insert on the tibia on the medial side. So therefore, whenever we flex, it gets relaxed. So at the time, it will not take action. So because when it is extended, it was totally stretched and it was contracted. Therefore, the abduction is not possible. But whenever it is flexed, the abduction of hip is possible. So it indicates that that is Gracely's contraction. And this is popliteal angle for hamstring contracture. Okay, so these are different. This is for adductor. See, adductor longus will be here. If you really abduct and palpate here, there's a cord-like structure. Okay, so there is a cord-like structure here known as adductor longus. Okay, this adductor longus, if at all it is spastic, we can't abduct. Okay, there will be contracture of that testing for adductor. There will be contracture of it, and we can't abduct it, and we can feel it properly if you there is a cord-like structure on the medial side at the groin area. And this silver skyal test, see what happens here is, here these muscles are gastrocnemius and soleus. So what happens, gastrocnemius soleus will originate at the tibia, but gastrocnemius will originate from the femur. So whenever we extend, there will be stretching of this gastrocnemius muscle. Okay, so what happens, if there is both gastrocnemius and soleus contracture, on extension we can't dorsiflex it. On flexion, we even on flexion we can dorsiflex only partially if there is both contractures, because on flexion of the knee, this gastrocnemius will get relaxed but not the soleus. Okay, but if there is only gastrocnemius contracture, then what happens, on extension we can't dorsiflex the foot, but on flexion we can easily dorsiflex the foot. So that is isolated gastrocnemius contracture. Okay, so gastrocnemius and soleus, we can differentiate it, their contractures with silver skyal test. So there are different deformities. In hip we will have flexion, adduction, interrotation, subluxation, dislocation. Not all, but these are the most common. Okay, in knee flexion, recurvatum, patella alta. Patella alta means patella will be above. Okay, than its usual level. Okay, there will be knee flexion, recurvatum, patella alta. Ankle equinus. See, you can see equinus, and there will be equina varus or valgus. And foot there will be cavus. Okay, cavus deformity, clatos, hallux valgus, forefoot adduction, and gait will be intoeing and scissoring gait. This scissoring gait will come due to adductor spasm, because these adductors are very spastic. What happens? The hip cannot abduct. Okay, therefore it will be there will be scissoring gait. This is known as scissoring gait. Okay. So there are different deformities present in lower limb. In hip, flexion, adduction, interrotation, subluxation, dislocation. Knee, flexion, recurvatum, patella alta. Ankle, equinus, varus and valgus. Foot, cavus, hallux valgus, clatos. So there are different deformities present in the lower limb. In upper limb, we'll have the flexed wrist, pronated forearm, flexed elbow, thumb in palm deformities. See, okay, here you can see thumb in palm deformity, because these are all due to spastic contractures of the muscles. And there is something known as bone deformities, like torsional deformities. See, generally femur will be in anteversion, 15-degree anteversion to that of tibia. Okay, normal. But in this case, there will be abnormal anteversion or abnormal retroversion. Okay, because of this anteversion problem, there is intoeing gait. Okay, the toes will be inside while patient is walking. So these we can know whether this torsions are present or not. We can know by seeing the Craig's test. In Craig's test, we'll flex in prone position. We'll flex both knee. We'll flex the knee and we will abduct it in such a way that GT should be touching the couch. The greater trochanter prominence should touch the couch. So, and we'll measure this angle. So in prone, knee flexion 90 degree with one hand over the greater trochanter, the other hand internal external rotates the leg till the trochanter is felt most prominent. The angle of version is the angle subtended by the imaginary vertical to long axis of the leg. So this angle is the angle of anteversion or retroversion. Okay, and that is for femoral anteversion, femoral torsion problem, Craig's test. And for tibial torsion problems, there is thigh foot angle. Okay, so we'll flex like this in prone position, and we'll draw a straight line on the thigh, and we'll draw a straight line on the foot, and we'll measure this angle. This is thigh foot angle. Okay, and gait analysis is very important. Okay, how the patient is walking. Okay, and there is see, this is pure equinus gait. Equinus means plantar flexion. Okay, and calcaneus gait is dorsiflexion. So in this cerebral palsy, there will be equinus gait, or there may be crouch gait. Crouch gait means, see, there is flexion at the hip, there is flexion at the knee, and there is plantar flexion of the foot. So this is known as crouch gait. Okay, and scissoring gait, as I said you before, while walking, this foot crosses this foot and this foot crosses this foot. So this is known as scissoring gait, and it will be very difficult to walk. So gait analysis is done in a separate room where, okay, electrodes are attached here, and the patient is analyzed with this graphical presentation. Okay, and this is a gross motor function classification system. Okay, GMF says so level 1, 2, 3, 4, 5. Okay, and in one, child can walk at home, school, outdoors, and in the community they can climb stairs, everything. It appears normal. Okay. Whereas in level 2, child walk in most sitting and climb steps holding on railing. So he cannot walk without holding this. Okay, he can walk only with holding this. And in case 3, he can walk only with some walking aids. Okay, but he can walk or he can go, oh, but only with some aids. And here he can't stand properly without any back support. He can't stand. In 5, there is no head control. There will be stooping of the head. So we have to control the head stooping with this bar. Okay. So these are all the different GMFCS classification. In summary, gait analysis has to. So what is the purpose of gait analysis? To clearly document the 3-dimensional movement of the lower extremity, to document changes in the gait over time as patient grows, to allow pre and post-operative comparisons after tendon or bone surgery, to analyze the rotational profile of the patient, to confirm his surgical plan when needed. And X-ray, what we can see is, see in the what happens is he get fixated or dislocated. So it will draw Reimers migration index. What is Reimers migration index? So we'll draw a line through this okay, a line, and on the border of the acetabulum. Okay, and this is the inner border. So this part A should not cross this. If it had crossed this, or this space of A was increased, it means it is subluxating. So percentage femoral head with no acetabular coverage. So this is the acetabular coverage. So this is the part without acetabular coverage. So if it is less than 3%, it is at risk. If it is greater than 3%, it is sensitive. So this is the importance of Reimers migration index. Okay. So based upon, so these are the different stages: hip at risk, hip at subluxation, spastic dislocation, and windswept. What is windswept is abduction of one hip and adduction of the contralateral hip. So different, opposite way. So both will be swept to one side. This is abducting and this is adducting. So like this is windswept hips. So this is by X-ray. Okay, so these are all about evaluation, and now we'll go with management part. Okay, management part of cerebral palsy. So the management part, it's a actually only spastic things should be treated. Remember first that thing we have to remember. It's a multidisciplinary team approach, including physical, occupational, speech therapy, orthotics, nutrition, social work, orthopedics, and pediatrics. Okay. The second, which can be a source of frustration, is that the treatment currently available correct the secondary deformities only, not the primary problem, which is the brain injury. So the primary problem itself stays inside the brain. So we can't remove that damaged brain, right? So we have to correct the secondary deformities due to the damage caused by the brain. Okay. So goals of management: achieve the child with CP becomes the adult with CP. So our goal is mainly communication, mobility, walking. He have to walk on his own. He have to do his daily living activities on his own. So that is our purpose. We can't make him totally normal. Okay, only thing is we can correct the deformities and we can make him to walk and we can make him to do his daily routine activities. Okay, so involve parents as much as possible. Do not raise false hopes which could increase frustration. We shouldn't tell them that a patient will be treated 100% successfully. No, because even after treating, there will be recurring of the deformities. Okay, so control spasticity, physiotherapy, orthotics, and orthopedic surgery. So how to control spasticity? See, there are medical approaches and there are surgical approaches. Okay. So if you take the medical approaches, means to decrease the spasticity, okay, there may be intrathecal baclofen, okay, this mimics the GABA, and there may be botulinum toxin, okay, which relaxes the muscles and decreases the spasticity, okay, and there may be selective dorsal rhizotomy, okay, that is the surgery to cut the nerve roots in the at the spinal cord level, okay, so we can give diazepam, dantrol in anti-epileptics, okay, and physiotherapy to improve the movement, active exercises, passive exercises, stretching, splints and bracing, family education. So the main goal is the strengthening of the weakened muscles and prevention of the contractures, gait and balance training. So we have to train him to do his daily routine activities and for him to walk. So that's it. The main therapy deals with make him to walk on his own and do his daily routine activities. Okay, there may be castings or orthosis. There are different orthosis: ankle foot orthosis, hip knee ankle foot orthosis. Okay, these are different types of orthosis to support the limb and to prevent the contractions and to give support to the weakened muscles. So so primary deformity needs treatment, whereas compensated deformity can be improved without intervention. Okay, if you correct the primary deformity, compensated deformity will correct on its own. So surgery prevents structural changes, usually early improve. So as early as possible we have to do the surgery. And for surgery, so spastic type are good for surgery. Okay, only spastic type are good for surgery, and 3 to 12 years is better age, and the IQ is good for these people. Okay, and yeah, this is important. Single stage multi-level approach is better, and not multi-level single stage approach. It implies that at the singles and on the single day, on the at the single time, we have to do the different muscle corrections, but we should not do it one at one time, because if you correct one deformity, other deformity will aggravate. Okay, so therefore single stage multi-level procedure preferable to stage the single level procedures, because hospitalization, immobilization, rehabilitation time and the number of anesthetic exposures decrease. Surgery should not be unduly staged one by one. Okay, it should be done at a time, and all deformities should be corrected at that time alone. Okay, otherwise there will be different deformities. Okay, if you correct TA, then hamstrings will aggravate. If you correct hamstring, then psoas will aggravate. If you correct psoas, then tragus femoris will aggravate. So we have to correct at the single stage itself. Okay, what and all we have to correct? Coming to hip flexion contractures and hip adduction and scissoring gait, subluxating and dislocating hip. Okay, rotational deformities of femur and tibia, then foot equinus, equinovarus, these all. So first we'll deal with hip problems. Okay, hip adduction and flexion deformity, hip at risk, hip subluxation, hip dislocation. So flexion deformity is the main problem, lies in the iliopsoas. So what we'll do, we'll lengthen the iliopsoas. Okay, so this is known as iliopsoas recession. Okay, we will break. Okay, or we'll do iliopsoas tenotomy, or else we'll do jetplasty. See, we are cutting the iliopsoas contracture. We'll cut the iliopsoas and we'll suture like this. This is known as jetplasty. Okay, and or else we can do tenotomy, or else we can do recession. Recession means we'll cut partially and we'll stretch it. Okay, so this is for flexion contractures, tenotomy, recession, or jetplasty. Okay, then adduction deformities. Adduction deformities, the problem is with adductor longus. So what we'll do, we'll stretch like this, and here there will be adductor longus muscle, and when we'll do the adductor tenotomy, okay, we can cut that adductor longus so that adductor contractures will be relieved. And there is something known as pseudo adduction. For suppose there is problem with the femoral torsion. Okay, there is femoral whenever there is femoral torsion, it appears like adduction deformity, and child sits in this position. This is known as W position. Okay, so this is known as W position. Whenever child sits in W position, it implies there is pseudo adduction. It is not adduction deformity, and it is not due to adductor longus. If you wrongly release adductor longus, there will be more abnormalities. So therefore, we have to do. We have to address with the problem of femoral anteversion and not with adductor longus. Okay, this is known as pseudo adduction. And there are subluxation and dislocations. Okay, the hip may be dislocated or subluxated. As I said you before, Reamer's migration index. Okay, so this is almost like dislocating. Okay, there is no established coverage, it came out. So for these, what we'll do is varus derotational osteotomy. Okay, okay, so for this, how to treat operatively is we'll do varus VDRO. VDRO means varus derotational osteotomy. So what we are doing, we're increasing the coverage of the femoral head. Okay, what we did here, see here it was not covered, but here we'll cut here. Okay, we'll cut almost at the level of the left trochanter, and we'll bend this. Okay, of course there will be shortening, but there will be but it will not get dislocated. See, there is improved coverage, and we'll keep a plate. Okay, 90-degree angle blade plate. So this is before surgery, this is after surgery, after varus derotational osteotomy. Okay. And sometimes what happens is there will be painful dislocation. There may be arthritic changes. It is very painful. So in small children, we can't do total hip arthroplasty and all. Therefore, what we'll do is we'll remove that part. Okay, totally. This one is surgical resection. Okay, and here we'll keep some muscles, iliopsoas and all, to give some cushioning effect. Or in very older cases, we can do orthodesis. Means we'll combine both head of the femur and acetabulum. Okay, we'll debride it, and we'll keep some bone graft, and we'll fuse the joint completely.
and knee deformities. Coming to knee deformities, there will be flexion deformity, recurvative of knee valgus, and patella alta. So how to address these? So coming to flexion deformity, see, flexion deformity will come mostly due to hamstring, okay, hamstring tendon contractures. So these hamstring tendons, we can do recession. Okay, anytime remember, there will be tenotomy, there will be recession, or there will be Z-plasty. So here for hamstring tendons, we are doing recession. So this is recession. We'll cut it partially and we'll stretch it. Okay. Or distal transfer of rectus femoris. So this rectus femoris which gets inserted here, so this can be released and this can be inserted at that position itself. Okay, patella alta means patella will be raised upward than its usual position. It is due to quadriceps spasticity. So what we have to do, we have to release the quadriceps, or we have to do some really can lead to repeat. We can release the quadriceps spasticity can be released by dividing it by doing recession. Foot deformities, equinus deformity, varus or valgus deformity, calcaneus deformity, cavus deformity. So silver scale test, as I said earlier, that we should know whether the contraction gastrocnemius or soleus. So based, if you know that is only soleus contraction is there, we can release only soleus. So like that. So this is silver scale test. The equinus deformity, we can release TA. Tender Achilles can be released. Okay, here tender Achilles will be there. There is severe contraction of the tender Achilles. Therefore, it is an equinus. So we can release the TA. Or bracing spasticity reduction. Okay, so this is TA, tender Achilles. Okay, we can do Z-plasty. This is Z-plasty. Okay, Z-plasty of Achilles tendon length, or we can do percutaneous lengthening. See, we will cut on the opposite sides and we'll stretch it. Okay, just like a recession. See, this is lengthening of gastrocnemius and soleus. Okay, we'll just cut partially, not totally, and we'll stretch the muscle to relieve the contractions. These are different techniques. Okay. So mainly understand that we have to stretch the muscle. So either by recession or we can do tenotomy, but tenotomy we shouldn't do every time because we have to remove the insertion part to do the tenotomy. So therefore, either we have to do recession or we have to do the Z-plasty. Okay. So initially we will deal with medical like baclofen, okay, and botulinum toxin and all. If it is not get relieved by that, then we'll go for surgeries, and surgeries are also only spastic types, not for ectoid and myxoid types. Okay, and we can for varus and all, we can also do lengthening of the posterior tibial tendon. Okay, posterior tibial tendon will cause inversion. Okay, it leads to varus. So therefore, we can do it lengthening by division of tendinous portions only in posterior tibial tendon into two levels. And there are tendon transfers also. If there is contractures here, what we'll do is we'll remove the posterior tibial tendon and attach anteriorly. Okay, so that it will increase dorsiflexion on its contracture. Coffer split transfer. So here also same thing. Posterior tibial tendon is transferred anteriorly. There are many surgeries. You do not remember all this, but you should know the basic concept what it is. For suppose if the patient is very adult and the contraction is very severe, we can go for arthrodesis, triple arthrodesis. So triple arthrodesis will deal with TN, TC, and CC. Okay, calcaneocuboid, talocalcaneal, and talonavicular. So remember this TN, TC, and CC. And varus we can also address it by doing calcaneus osteotomy. Okay, a wedge osteotomy for calcaneus and decreasing the varus. Okay, so Grice, these are about arthrodesis, Grice extraarticular arthrodesis, and the normal triple arthrodesis we can do with screws. Okay, so different methods, but so this is at the end stage. If the patient contractions are very aggressive, and particularly in foot and all, we can go for arthrodesis. Okay, if tendon transfers or tendon release was not working, then we go for arthrodesis like this. And this is for bunion, dorsal bunion, hallux valgus. Hallux valgus is that our great toe. Okay, great toe is laterally deviated. Okay, or medial deviation of this metatarsal. Okay, this is hallux valgus. and intoing. This one I already said you, because of torsional problems. Here torsional problems should be corrected. We should see whether it is torsion in the femur or tibia, and then we should do the derotation osteotomy. Means if there is severe retroversion, then we will do the osteotomy at one place, we'll rotate it and we'll fix it with plate. That is not derotational osteotomy. So that's it. Okay. So ultimately the main thing is there is an insult to the brain, particularly at the time of birth itself. Okay, it may be due to some maternal causes or a child some hypoxic causes. Okay, there are multiple causes which we have seen. So because of these causes, some part of the brain gets affected, either pyramidal part or extrapyramidal part. So based upon that, we'll get the features present in the child. But most of the children are spastic type. Okay, so there will be contractures. Most of the patients, almost 90% of patients, they will be spastic type. So, and the surgery is also only for spastic type, not for that myxoid or ectoid or chorea type. Only for this spastic type we'll go for surgeries. And before going for surgeries, we have to know properly which compartment, either it is anterior, posterior, okay, whether it is concerned with leg or it is concerned with thigh. So based upon that, it is a torsional problem of femur, a torsional problem of tibia. So by proper clinical evaluation, by proper gait analysis, by proper analysis of clinical features, and we have to know what structure got affected, either it is bone, or either it is dislocation, either it is subluxation, or either it is rectus femoris problem, either it is gastrocnemius, soleus. So we should know each and every muscle. We have to understand all the muscles in a lower limb or upper limb to know to which part we have to deal with. So based upon that, we have to deal with that particular part, and we have to do, if it is concerned with muscle contractures, either we have to go with tenotomy or recession or tendon transfers. Okay, so or tendon jet plastic. Okay, so based upon the our clinical evaluation, based upon our examination, we have to treat the patient. So if you treat at different stages, and this was very important, single stage multi-level surgeries we have to do, not single level and multi stage reference, only single stage and multi-level. Okay, we have to do all the surgeries at a time, because if you do at different times, the deformity will aggravate. So that is very important. If you want, I will show you few videos. So this is our Duncanelli test for rectus femoris. See this? So this is scissoring gait. If you see here, there is scissoring due to erector spasm, and you can see also equinus, okay, and varus, everything. Okay, to look for hamstring spasticity. Okay, they are looking for popliteal angle. See, he is abducting the hip, the Bresley's Phelps test. Sorry, there is disturbance. See, there is equinus. Here there is no scissoring gait. Okay, only equinus, and there is some, see, it appears like some valgus at the knee. So they are all different CP patients presenting differently. So we have to evaluate them. We have to know what part of the muscles got affected. So most commonly they will be lower limb affected, and mostly they will be spastic type. So based upon the, so you can't make him completely normal. Okay. See here there is knee valgus and there is intoeing gait. If you can see properly, there is intoeing gait. See, the toes are inside. It may be due to femoral torsion or tibial torsion. We have to evaluate it. Femoral torsion by Craig's test and tibial torsion by thigh foot angle. So clinical examination and gait analysis is very important. Okay. So that's it. Okay. So that is the importance of CPs. We have to evaluate it correctly and we have to know what part got affected and we have to treat that particular part. Okay. Thank you all. Thank you all guys. Class is over. Okay. Oh, 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 oh.